Hello everyone, I am Dr. Sapkal here. The title for discussion today is Examination of Antenatal Case after Viability, means after 28 weeks of gestation. Let us see it on the blackboard. Hence, when you are doing the examination of abdomen in an antenatal case, the patient should lie down on a bed, okay, and the legs of the patient should be flexed and cover the lower limbs of the patient. Then you have to palpate the, first you have to do the inspection, then palpation. When we are inspecting the uterus, abdomen, there you have to examine the whether abdomen is distended or flat and whether it is over distended. It may be over distended with the umbilicus bulging in cases of twin pregnancy and hydramnios. So, like that you look for the scars, visible scars over the abdomen also. And when you palpate the patient, you take the consent, verbal consent of the lady, and then warm up your hands. When you are standing on the right side, if you are lefty, you stand on the left side of the patient. If you are right handed, stand on the right hand of the lady. Okay. Start palpating the uterus from the xiphisternum and come down where you feel for the resistance of the uterus here. The place where you feel for the resistance, there you keep ulnar border of your left hand, and that is how you comment about the height of uterus in weeks. Let us see on the board this thing. Here in these cases, this is the xiphisternum. I am on right side. I palpate with the index finger of my left hand, and the place where I feel for the resistance of the uterus, I keep ulnar border of my left hand, and if it is here, I will keep my left hand over here. If it is here, I will keep my left hand here, like that. So, we predict, first we predict the height of the uterus, it is known as fundal height. Next, we do the fundal palpation. This part of the uterus above the attachment of fallopian tube is the fundus. So, this part of the uterus we palpate, it is known as fundal palpation. It is not grip, fundal grip, it is fundal palpation. Okay. Next, you do two examinations, they are known as first pelvic grip and second pelvic grip or reverse pelvic grip or Paulic grip. So, these two examinations are different. First, these two examinations we will learn. Okay. What about the height of the uterus? The height of the uterus increases from first trimester, means after 12 weeks it is palpable per abdomen. So, at the pubic symphysis it is 12 weeks. So, remember this fetus is growing slowly till term. Term is full term pregnancy, is more than 37 weeks of gestation, and pregnancy is of 40 weeks. So, till this thing, till xiphisternum it is 9 months. So, we consider xiphisternum as 36 weeks of pregnancy. From 12 weeks the uterus is palpable per abdomen, till 36 weeks it is up to xiphisternum. 36 weeks is equal to, you remember like this, 9 months, total 9 months, pregnancy is of 10 months, but it is up to xiphisternum till 9 months or 36 weeks. The part below the umbilicus you divide into two, midway between the umbilicus and the pubic symphysis is 16 weeks. So, this fundal height is 16 weeks of pregnancy. Lower margin of the umbilicus is 20 weeks, this 0 you remember umbilicus. Upper margin of umbilicus is 24 weeks. So, it is a table of 4. Okay. All 4 quadrants indicates 4 weeks. So, like that you calculate the fundal height. The part between the umbilicus and the xiphisternum you divide into 3. 4 fingers above will be 24, 28 sorry, and 4 fingers still above will be 32 weeks of pregnancy, and this part is 36 weeks of pregnancy. That is how we calculate the height of uterus. Now, what about 40 weeks of pregnancy? 10 months, the pregnancy is of 10 months. In these cases, the height of the uterus descends and the flanks are bulging like this, and it comes up to 32 weeks. So, whenever the fundal height is of 32 weeks with the flanks are bulging, in those cases we say it is 40 weeks of pregnancy. We say it is 40 weeks of pregnancy. So, that is how briefly we assess the height of the uterus clinically. This is known as clinical assessment of the height of the uterus. So, clinically how do you assess? Midway up to pubic symphysis it is 12 weeks, midway between the umbilicus and pubic symphysis is 16 weeks. Then below umbilical border is 20 weeks, above umbilicus is 24 weeks, 4 fingers above 28 weeks, 4 fingers above 32 weeks, 4 fingers above up to xiphy is 36 weeks. After 36 weeks, the height descends and there is bulge in the flanks. This is known as lightening, or it is a welcome sign. In those cases, the height of the uterus is 40 weeks. After calculating the height of the uterus, we predict whether this fundal height is corresponding with the period of gestation or not, because in certain cases it may be less, it may be more. In which cases the height of uterus will be more than period of gestation, like when it is over distended naturally, twin pregnancy, hydramnios, twin or multiple pregnancy, hydramnios, these cases the height of uterus will be more. Then next, in which cases the height of the fundus of the uterus will be less? Intrauterine growth restriction. It is known as IUGR. It is always associated with, most of the time it is associated with oligoamnios. So, always whenever you utter the word IUGR, along with that you say oligoamnios. Liquor is less. Or transverse lie. The fetus is transversely placed in relation with the maternal spine, transverse lie. This is vertical lie when the height will correspond. Next, intrauterine death, where it is a dead macerated baby. In these cases, the height of uterus will be less. In these cases, the height of uterus is more. So, you correlate whether the fundal height is corresponding with the menstrual age. What is menstrual age? Suppose we take the menstrual history, past menstrual history, the periods are regular, and last menstrual period we note, and according to the Niggles formula, we calculate the expected date of delivery. So, according to LMP, whether the fundal height is corresponding to 24 weeks, 6 months amenorrhea, it should be 24 weeks, 7 months amenorrhea, it should be 28 weeks, like that. So, we put a comment on the file, case paper is the fundal height is 28 weeks, it is corresponding with the period of amenorrhea, or it is corresponding with the menstrual age, or even with the sonographic age, we should note whether it is corresponding or not, because according to that my diagnosis will change, it will differ. Next, what you do is, next palpation is concerned with this dummy and pelvis. So, let us learn with this. The patient is on the bed with the flexed legs. The lower extremities should be covered for privacy, and if you are a male person examining the lady, the female attendant should be stand by, and I stand on right side of the patient, palpate with the index finger of left hand, palpate from the xiphisternum, the place where I feel for the resistance of the uterus is height of the uterus. So, this is the height of uterus I calculated, we have discussed it. Now, next palpation is the fundal palpation. Fundus is the top of the uterus. So, this portion is the top of the uterus. So, you keep two index palmar surface of the tips of the palm on the midline, and the only fundus of the uterus we palpate and examine what is there exactly. If it is soft, bulky, non-palatable structure is felt, it is breech. If it is reverse, I will say hard, globular, bulky, hard globular structure is felt, palatable, it is palatable. So, in breech presentation, head will be felt. Normally, your comment will be soft, bulky, non-palatable structure is felt, it is breech. These are the findings on fundal palpation. Next, we come down, lateral palpation on this side and this side. For lateral palpation, you keep 4 fingers of one hand on one side, like left hand I will keep then 4 fingers like this on left side of the mother, and with the right hand I will palpate this surface. I have to palpate, I have to sweep these 4 fingers over the mother's abdomen like this. This should be the movement. The movement should not be like this, it should not be like this, it should be like this. They should sweep over the abdomen of the mother. So, this way I can make out that there is a uniform back. So, you make a note on which side the back is. So, this side the back is on left side of the mother. So, it is left position, because the back of the fetus denotes the occiput. The occiput is the denominator, it indicates whether it is left side, right side. So, on left side the back is felt, on the other side you can make out these irregular limbs. So, the limbs are felt on the left side, right side, sorry. So, the limbs are felt on right side and the uniform back is felt on the left side. If you are in doubt, quickly confirm it by auscultation, where you will auscultate midpoint between the anterior superior spine and umbilicus, this place. You auscultate the fetal heart, it will be heard. So, in anterior position, like vertex left occipital anterior position here, it will be heard in the midway, and below the umbilicus, midway between the spine and the umbilicus, you can hear the fetal heart here. In cases of posterior position like this, the fetal heart will be heard in the flanks, and this back is also felt in the flanks. It is not in front like this in anterior position. In posterior position, the back is felt in the flanks. Okay. So, this is the lateral palpation. I can make out which side the back is, which side the occiput is, and I can determine the position of the fetus in the uterus. Okay. Now, let us learn the 2 important grips. They are known as pelvic grip. Here we have discussed it. This is the pelvic grip. First pelvic grip and second pelvic grip. Okay. There should not be any confusion about these grips, because there are different terminologies used. All these methods are known as Leopold's maneuver, 1, 2, 3, 4, like that. And the pelvic grips are made out to identify which pole of the fetus is in the lower uterine segment. So, first pelvic grip, what shall I do? This is the fetus here like this. I will keep the ulnar border of my right hand over the pubic symphysis, fix it. Then 4 fingers on one side and thumb on the other side. So, this is how I take the grip. This is known as first pelvic grip. The movement of my hand should be like this. It should not move like this. The movement of my finger should be this way, this way. So, just toss the head. So, I will grasp the head and try to move it. If it moves, my comment will be head is floating. If it is well flexed, the occiput will enter first, and if I try to move it, it is not moving. So, it is fixed. So, my comment on first pelvic grip examination will be head is floating, either one comment, second comment is head is fixed, that is all. This examination can also be done by the other method, that pelvic grip is, I put my hands like this, my direction towards the patient feet. If my 4 fingers go below the head, it is floating. If my 4 fingers are divergent like this, it is fixed head. So, like that, this examination can also be done, whether pelvic grip is convergent when it is floating, divergent when it is fixed, like that. So, this is all about first pelvic grip examination. Now, what is left is second pelvic grip examination. This second pelvic grip examination, this is not done as a routine. It is not required at all in a full-term patient who is not in labor. So, in the examination, when the head is floating on the first pelvic grip examination, head is floating, you should comment second pelvic grip examination I have not done because the head is floating. Why you should comment like that? Because whenever head is floating, it is bound to be deflexed. That means by second pelvic grip examination, you understand whether head is well flexed like this or deflexed. Why I want to know whether it is well flexed or deflexed? If the head is well flexed, normal vaginal delivery within normal duration is possible in labor. When it is deflexed, vaginal delivery will be prolonged. There is a risk of prolonged labor. Naturally, I will assess this thing with the onset of labor pains. In the examination, when the patient is not in labor, you are supposed to comment only about first pelvic grip examination, whether it is floating or whether it is fixed. Otherwise, you should comment second pelvic grip examination I have not done because head is floating, it is bound to be deflexed. Now, in which cases the head is, how the second pelvic grip examination is done, let us learn, try to understand. I am standing like this. The first prominence on the side of the back will be occiput. The other first prominence on side of the limbs will be sinciput. So, when the head is well flexed, occiput is at a lower level than the sinciput. So, that is how we make out it is a well flexed head. Now, if it is like this, it is reflex head. So, second pelvic grip examination tells us about whether it is well flexed or deflexed. That identification is important in cases of labor. Tell me the cases, conditions where, just think of the conditions where the head will be deflexed. Occipito-posterior position, when it is a right occipito-posterior position like this, the head is deflexed. That we should identify at the time of labor, or you may identify before labor also, but in these cases the head is always floating. Now, one more important thing about the first pelvic grip examination, if your patient is a primi gravida and she is at term, means 40 weeks with the flanks bulging, and your comment is head is floating, it is wrong. Why so? Because in primi gravida the head gets fixed or gets even engaged, means it enters into the pelvic cavity 15 days before expected date of delivery. So, it has to be fixed head. It has to be well flexed head in primi gravida. However, in multigravida you are correct. When you say first pelvic grip, the head is floating. When it is not movable, it is fixed, that is all. So, when on first pelvic grip head is movable, you say head is floating. When it is not movable because the occiput has crossed the pelvic brim, then it is used. Then you say it is fixed. When it is not palpable at all, you say it is engaged. In these cases, second pelvic grip examination, the finding will be divergent. When it is floating, convergent. When it has crossed the pelvic brim or it is fixed, the findings are divergent. Okay. So, this is all about the pelvic grip examination. Let us learn in detail about all steps of palpation and examination of the patient with the help of slides and diagrams. Okay. Let us learn details of this examination on the slides. Okay. So, when we are doing examination of the patient, first you should do the general examination, followed by systemic examination like other cases of medicine surgery we are doing. Abdominal inspection, then palpation, then auscultation is important. We do it in the stepwise manner. Auscultation is done to know whether fetal heart sound is there or not. Regularity of the fetal heart sound here is important if patient is in the labor. If she is not in the labor, then regularity is not important. Just measure the heart sounds, heart rate. Okay. Lastly, you should inspect the local inspection of the vulva and introitus for the leaking of the liquor, bleeding per vaginum or any discharge per vaginum must be commented. post-speculum and PV examination is not required for the undergraduates, postgraduates are supposed to do it in the practical examination. Now, in these cases, there is some system which all physicians or doctors should follow, like certain privacy should be maintained, and when you have to take the verbal consent of the lady also when you are examining the lady. Male personnel, if examining the patient, in those cases the female attendant should be standby. When you are examining the lady, make sure the patient is relaxed. So, how can you make the patient relaxed? How can you make the abdomen relaxed position? Give shoulder rest support by a pillow and ask the lady to flex the legs, so that abdomen wall is relaxed and you can quietly palpate the patient's abdomen and there is no discomfort to the lady while doing the palpation. One more thing which you can take care of is warm up your hands when it is a winter season. When you are doing the inspection of the patient, look for the umbilicus, whether it is protruding, it may be protruding or it may be normal. Protruding in which cases? When she is a patient of hydramnios, the liquor is excess, or there it is a multiple pregnancy case where triplets may be there or twin pregnancy may be there. Linea nigra, hyperpigmented linea alba, it is a midline mark. So, if it is hyperpigmented in pregnancy, so you must comment that linea nigra is there, means I am dealing with a pregnant lady. Then stria gravidarum, they are stretch marks due to present pregnancy or the past pregnancy. In the present pregnancy, they are in the primigravida, they are dark color, and in multigravida they are silver like color. So, stretch marks or stria gravidarum are present, means you are dealing with a pregnant uterus, gravid uterus. Then look for the marks of the previous operation like laparotomy, cesarean section. For laparotomy it may be laparoscopy scars also may be there. Laparotomy it may be vertical midline, or for LSAs usually we give transverse scar over the lower abdomen, look for that. Look for the puckering of the scar and the keloid formations and hernia at the scar site also. Hernial orifices are also look for with femoral and inguinal hernia, they should be noted on the inspection of the abdomen. Okay. Abdomen is over distended or stretched with the stretched skin in cases of multiple pregnancy in hydramnios, and with the probably there may be markings, vessels, capillaries distended over the abdominal wall. Suprapubic flattening, this is one important finding which is seen in cases of occipito-posterior position, because the bulge of the occiput goes posteriorly. Normally the back is anteriorly and occipital bulge is also over the pubic symphysis. That bulge is missing in cases of occipito-posterior position. It indicates whenever there in these cases there will be suprapubic flattening. It indicates it is a occipito-posterior position. Okay. Next, you are doing the palpation of the abdomen. We have discussed the fundal height of the uterus. Palpate with the xiphisternum and with the index finger of your left hand and palpate below it, go on palpating below it. Wherever you feel the resistance, you keep the ulnar border of your left hand and predict the size of the uterus. Whether it is corresponding with the period of amenorrhea or not, document on the paper. Okay. So, the fundal height, clinically height of uterus may be 36 weeks. You say it is corresponding with the menstrual age. If sonographic findings, previous sonographic record is there, you say it is corresponding with the sonographic age. Look for whether height is more or it is less than period of gestation. Then if it is more than period of gestation, she may be a patient of hydramnios twin pregnancy. Less than period of gestation, it may be a transverse line. It may be IUGR with oligomnias. She may be a patient of intrauterine death with a dead macerated baby. So, this is how height of uterus is important clinically. This is the grossly I had drawn the photograph of this abdomen. Up to xiphi is full, 9 months pregnancy, 36 weeks. Up to pubic symphysis it is 12 weeks. After 12 weeks of gestation, the uterus is palpable per abdomen, umbilicus 0 indicates 20. So, below umbilicus is 20 weeks, above umbilicus 24 weeks. So, this is the 24 weeks is a period of viability. Nowadays, we consider it 28 weeks. 4 fingers above umbilicus 28, 4 fingers above 32, 4 fingers above 34 and lastly 36 weeks. At 34 weeks, it can be 40 weeks with the bulge of the flanks, then it is known as full term pregnancy. Okay. So, it is a formula 4 fingers and that is how 2/3 distance between umbilicus and zippy we say it is 34 weeks. 1/3 is 40 weeks with the flank bulging and 4 fingers above umbilicus is 28 weeks. So, this is how the fundal height is calculated and duration of gestation is estimated with the help of 4 fingers only manually. At term, the patient gets little comfort zone. She goes into comfort zone because the height of the uterus descends and there is a bulge in the flanks. In these cases, the head engages in the pelvic cavity and due to that, because of formation of lower uterine segment, patient get relieved of respiratory discomfort. This feeling is known as lightening. It is felt before 2 weeks before expected date of delivery and of course, it is a welcome sign. Next methods, just remember, do not get confused, there are 4 Leopold's manual, they are the same methods. So, 1, 2, 3, 4 like that, they are labeled. For MCQ purpose, the terminology which is used is Leopold's manual. Okay. So, remember first and second Leopold manual corresponds with the fundal palpation and lateral palpation. Third and fourth Leopold's manual correspond with the pelvic grip. First pelvic grip is also known as Paulic grip and second pelvic grip is known as reverse Paulic grip. So, these different terminologies may be used in different cases. In these cases, you just remember which terminology is used for which manual. So, this slide is very important to understand in the beginning. Okay. So, second pelvic grip and first pelvic grip. First Leopold monomer or fundal palpation determines whether you are dealing with vertex presentation or breech presentation. What will happen here on fundal palpation? If I make out soft bulky breech, then it is vertex presentation. If I can make out head, means buttocks are below, breech is below. So, I am dealing with breech presentation. So, by fundal palpation itself, in cases of vertical lie, longitudinal lie, I can make out whether I am dealing with cephalic presentation or I am dealing with breech presentation. Second maneuver means lateral palpation determines which side the back is. If the back is on left side, means the occiput is on left side. If the back is on right side, means occiput is on right side. Naturally, on lateral palpation or second Leopold's maneuver, I can make out whether it is left or right position. I can make out whether it is anterior position or posterior position or transverse position. When the back is in the transverse direction, it is transverse position. When the back is extremely in the flanks, it is posterior position. So, like that we decide whether what is the position of the fetus in the uterus. Okay. Third and fourth manuals describes. Third maneuver, what it describes? It just gives information whether which pole of the fetus is occupying and whether the head, if it is occupying the lower pole, then whether it is floating or fixed. Okay. So, your comment on first pelvic grip will be just head is floating or your comment may be head is fixed. Fourth manual is a second pelvic grip examination where we describe whether it is well flexed, means it is occiput is at a lower level, sinciput at a higher level, it is a well flexed head. Deflexed head means occiput and sinciput both are at same level. So, this is how fundal palpation is done. Keep both hands touching, tips of the fingers touching in the midline. Don't go laterally, that is lateral palpation. So, in fundal palpation your hand must be over the fundus. What is the fundus of the uterus? Part above the fallopian tube. So, your comment will be soft, bulky, non-palatable, breach is present. Means breach is felt on palpation. Means what? You are dealing with vertex presentation. Vertex is down in the lower uterine segment. In breach presentation or first Leopold-Manuel examination, your comment will be hard, globular, palatable, head is felt and palpation of the head will be painful to the mother, or sometimes it may go below the liver and it may not be palpable at all. So, make out whether you are dealing with cephalic presentation or vertex presentation or you are dealing with a breech presentation. Okay. Second pelvic rib, you have to keep the 4 fingers of your both hand on either side and determine which side the back is. Sweeping movement of the palmar surface of the fingers should be there, no dipping movements, because if you dip your fingers it is painful to the mother, patient will have discomfort. Next method, so in this method lateral palpation I decide whether it is vertex left occipital anterior, vertex right occipital anterior, like that. Which position is common in anterior? Left position. Which position is common in transverse? VLOT, vertex left occipital transverse. Which position is common in posterior? Right, vertex right occipital posterior position. So, vertex right occipital position is also known as V3 position. Sometimes in the examiners in the practical, now they ask you hold the fetus in V3 position. What is V3 position? Vertex right occipital posterior position. What is V1 position? Vertex left occipital anterior position. So, that is how bilateral palpation I can make out which position I am dealing with. Next, in these cases the presence of the back on which side it is, whether left or right, I can confirm by auscultating the fetal heart sound. When it is anterior position, fetal heart sound is hardly 5 cm away from the midline. If it is posterior position, it will go far away in the flanks. So, it will be 10 cm away from the midline. That is how we make out whether it is posterior position and anterior position, and we take the help of the auscultation of the fetal heart. Now, next we will learn the two first pelvic rib and second pelvic rib. These are the two pelvic ribs. In the practical examination, when patient is not in labor, only first pelvic rib examination finding you have to make out. Here outstretched right hand is kept over the pubic symphysis, 4 fingers on one side and thumb on other side, and try to move the head. If it is movable, your comment will be head is floating. When it is not movable, your comment will be head is fixed. When it is not palpable, your comment will be head is engaged. You can confirm it by other method of examination whether fingers are convergent or divergent. Okay. Now, by this third Leopold maneuver or first pelvic rib, you understand whether it is a head or breech is occupying the lower pole. In cases of transverse lie, what will be your finding? Do not get confused. In these cases, the pelvic grip is empty, means you can't feel any fetal part in the lower uterine segment just above the pubic symphysis. So, about the second pelvic grip examination, you should say second pelvic grip examination I have not done because head is floating and it is bound to be deflexed, and my patient is also not in labor. This should be a comment. In the oblique lie, I may feel the head on one of the iliac fossa. This is a divergent or convergent, we will learn it. If the fingers go below the head, it is convergent. If the fingers are divergent like this, means head has crossed the pelvic brim, I cannot make out whether the head is there or not. So, that is divergent. By second pelvic grip examination, what information we get? Only two things we identify, whether a head is well flexed or deflexed. Well flexed means the chin touches the sternum and it is a vertex presentation. Deflexed means the chin is not touching, the head is little loose and it is a occipital posterior position. It favors deflection of the head. So, this examination is required and is not required for the floating head and when the patient is not in labor. So, by palpation I make out on one side, on the side of the limbs I will feel the sinciput, on the side of the back I will make out the occiput. This is how I decide whether it is well flexed or deflexed. Normally well flexed head, occiput is at a lower level and sinciput is a higher level. So, what is the leading part here? Occiput. So, what will happen with the labor? With the labor the occiput will move. However, when the head is deflexed like this, sinciput and occiput both are same level and it is seen in occipito-posterior position or occipito-transverse position where there is chance of deep transverse arrest, because the leading part is not the occiput here, it may be also sinciput. So, it depends. So, whenever there is deflection there is chance of prolonged labor if she goes into the labor. So, that idea I get by doing the second pelvic grip examination or Paulick grip examination. Auscultation, we have learned what is the significance. I can diagnose fetal distress. Acute fetal distress does not occur in pregnancy. It may occur with the rupture of membranes and cord prolapse or profuse hemorrhage in placenta previa. However, routinely in practice, most commonly, just you have to auscultate the fetal heart rate 140 to 148 or up to 60. 160 is normal, more than 160 is fetal tachycardia, less than 120 is fetal bradycardia. First tachycardia will happen, then the fetus goes into bradycardia. So, initially when it is 160, it is a fetal tachycardia, it indicates fetal distress. Fetal distress is common with onset of labor pain, it is due to uterine contraction, it may be so many reasons, maybe like cord around the neck, true knot in the cord, like that. So, there are so many prematurity is the commonest cause. So, you identify whether patient is in distress or not by auscultating the regularity of the fetal heart rate, that is important in labor. Ruptured vasa previa may be one of the cause for fetal distress in pregnancy, where the patient will have antepartum hemorrhage. Digital PV examination is very important to assess the condition of the cervix, that is known as Bishop score, to confirm what is the presentation and position of the fetus in the intrauterine pregnancy, and whether the head is well flexed or deflexed, whether it has rotated or not. This is important in labor also. So, that is how digital examination is important in pregnancy also and in labor also. We will learn what are the findings in digital examination and technically how it is done in the next class, and that is how we deal with the palpation of the patient or examination of the patient to get an idea exactly what is the presentation and the position of fetus in the intrauterine layer. That is how. Thanks for the patient hearing. I expect you a lot of confidence in the examination with the brief knowledge about the palpation of the patient. Once you palpate the patient in the examination or in the labor room, you are very confident about the obstetrics. So, go through these slides very often and try to understand what is the presentation and position in a patient. Thank you so much.